Welcome everybody to the February 2025 edition of IIDR Rounds. I'm Lori Burrows. I'm the Associate Director of the IIDR. And it's my pleasure today to introduce our two speakers. So our first speaker will be Dr. Marek Smieja. Thank you for helping me pronounce your name correctly. A professor in the Department of Pathology and Molecular Medicine at McMaster and an infectious disease physician and medical microbiologist at St. Joe's Healthcare in Hamilton. His research focuses on collaborative studies of respiratory and gastrointestinal infections. And today he'll be discussing research into COVID-19 and sexually transmitted infections at Hamilton homeless shelters. Our second speaker is Dr. Jessica Breznik. She's a postdoc in the Bowdish Lab. She holds a Global Nexus Pfizer Postdoc Fellowship in Vaccinology, using which she's studying SARS-CoV-2 vaccination and infection in older adults and other vulnerable populations. She got her PhD from McMaster's MedSci program in the labs of Dr. Don Bowdish and Dr. Deb Sloboda, where she studied the effects of chronic inflammation on macrophages. And today she'll be discussing COVID-19 infection and vaccination in Ontario long-term care and retirement homes. So I don't remember which of you is going to talk first. Marek? Okay, great. And for those listening, if you have questions, please put them in the Q&A box and we will answer them at the end of the two talks. Thank you. Over to you, Marek.
Thank you, Lori. And I have a bit of a sore throat, so you'll hear a deep, booming voice. It's always a pleasure to present at these rounds. I think it's always a lot of fun, both to kind of try to showcase what our own group is doing, but I always enjoy partnering with somebody who's way smarter than me and can present something sort of complimentary to me. So wonderful to present with Jessica today. So our group of really since the beginning of COVID has been doing studies of work in the homeless, although Tim O'Shea and I have gone back probably 15, 20 years, both in some of his work in Uganda and then his work in the homeless, where he's long encouraged me to work with him to try to figure out better solutions from the point of view of both better testing and better help with treatment of infectious diseases in our homeless. So today I've got the pleasure of presenting three different studies that are at different points of kind of being completed around infectious diseases in the Hamilton homeless. And for financial disclosures, we did receive a Merck grant for pneumococcus typing, which I'll be talking about. I won't be talking about C. diff today, but we also have a randomized clinical trial that we're part of a worldwide trial of Vedanta, a new combination of Clostridial probiotics for prevention of relapse of C. diff. And I'm also on the advisory council called the Ontario Public Health Emergency Scientific Advisory Committee. That's basically the Ontario Science Table with no fangs still left in it. We got defanged and we don't really talk to the media anymore, but we still try to advise the government. So I have three main objectives, if I could. The first is screening strategies for COVID. Secondly, we'll talk about strep pneumo colonization. And thirdly, we'll talk about sexually transmitted infections. And again, all of these see them as works in progress, whether I or some of my colleagues in this will present updates in the next few years. So we'll start with screening strategies for the homeless. The homeless obviously is a worldwide problem, but it's really come to the fore in the last couple of years, partly because of the overlap with injection drug use and overdose, and partly just out of a sense of almost helplessness in terms of how we as a medical community and as just a caring community can do a better job of figuring out true solutions for the homeless. And I don't have any magic solutions, but at least I've got some experiences to share with you of trying to improve the surveillance for COVID and trying to make it a safer place for both staff and clients in our homeless shelters. Now, some of you may have seen, I think I presented some of these about 2 or 3 years ago, but as way, and so the first couple of slides will be common to that presentation. But there was a really important paper that came out in the CMAJ Open at the beginning of the pandemic from Toronto looking at ICES data for Ontario. And they really asked the question whether homelessness is associated with worse outcomes in the context of COVID infection. And so basically they did a population-based retrospective study using these databases. I think that their definition of homelessness was no fixed address for at least 30 days prior to any of these visits. There were about 20 29,000 people where they could find that. And then they compared this with the rest of us, with 14.4 million Ontarians that are registered through OHIP and through various medical databases. And they looked at whether people have been received COVID testing. So did they have access to testing? Were they hospitalized? Did they end up in the ICU? And did they die? And the homeless in Ontario, as of this, Ontario-wide study, were more likely to be tested, about twice as likely to be tested. There were 4 times as likely to be positive. There were 20 times as likely to be hospitalized, 10 times as likely to require intensive care unit, and about 5 to 6 times more likely to die. So that was the data that we had, although we were already well into our screening studies at the time. But certainly homelessness in Ontario was associated with a lot of COVID, more severe COVID, more hospitalizations, and more deaths. And so back in 2020, Tim O'Shea approached me, and then we put a group of people together. We were able to get a bit of funding from HACSO and then later from the Ministry of Health. And so we initially put a study together as a randomized trial of 8 on homeless shelters, clusters of 2 that were randomized to 4 different strategies. I'll present that, but then we'll present what we did afterwards once we decided on a single strategy. So the 4 strategies that we randomized shelters to were either passive surveillance. If they got symptoms, they got a nasopharyngeal swab, usually by paramedics or by other staff, came to here at St. Joe's through the clinical lab, and we would give a diagnosis. We also had an arm randomized to nurse-collected nasopharyngeal swabs, nurses with all the PPE and the visors and all that would go, and for anyone who was willing, staff and clients, we would do a nasopharyngeal swab every week. And then we had 2 self-collected arms, an oral swab that was self-collected weekly, or an oral nasal swab, first mouth both sides, and then the nares both sides. And what happened? And again, I presented this to you about 2 years ago. Everyone in the passive surveillance basically told us this is not ethical. The staff don't want to come to work. It's a dangerous place. We can't wait until there are symptomatic people because we'll have outbreaks that way. So that arm was closed fairly quickly because of ethical concerns. The nurse-collected nasopharyngeal swab arm also had to be closed because within 2 to 4 weeks, everyone had abandoned that. People did not want weekly nasopharyngeal swabs, and so they abandoned that fairly quickly. We had no cases of COVID, but we also recognized that was not feasible, and we converted them over to oral nasal. So then we had 2 viable arms that continued for about 8 months. So the self-collected oral, where we did detect a small number of cases, well accepted. People would do this week in, week out. And then the self-collected oral nasal, which was also well accepted, done every week. But importantly, we identified 3 times more cases. So in the pilot study, in the randomized study, 15 cases versus 5 were detected with strategies, number 4 and number 3. So we decided on the basis of that, and just as COVID was really hitting Hamilton hard, that we would recommend the self-collected oral nasal, and we established an ongoing surveillance cohort. So this is data I don't believe most of you have seen before. This is part of a master's thesis by Julia Maciejewski in our lab, and she looked at 53 sites that had COVID testing done that our research lab would then, usually within about 6 hours, give results for. These included 14 emergency shelters, 24 supportive housing settings, 7 drop-in, 2 isolation centers, and 6 staff offices. And basically, they would be swabbed. Usually, same day we'd get a result. We would call that to usually Carrie Beal or one of the shelter health doctors. They would have the patient isolated. There was an isolation unit where people could be isolated as long as the numbers were small, and that worked while our outbreaks were small. We conducted just in that 1 year of 2021 about 42,000. Over the last 5 years, we've conducted over 80,000 tests altogether. These included homeless clients, mean age of 40, just over 50% were male, but it also included staff of those shelters. We wanted to offer them the same. They wanted that, and they, in fact, were quite active in the surveillance. Mean age of 39. Well, 30% of male and 70% female. We did try to figure out vaccination. We weren't very successful at that. Most didn't tell us about their vaccination status, but of those where we could determine vaccination status, the majority were vaccinated. So we don't know if that's true of the ones who didn't tell us, but bottom line is we estimate maybe 50% or so of the clients were taking advantage of vaccination and a larger number of the staff. And then we also looked at things like mobility because, if you're only in one shelter, you're less likely to cross-infect another shelter. And we thought that some of the staff would be going to multiple shelters, and some of them did, but in fact, clients were much more mobile, and that was important for spread of infections. And this is 2021. So what we have in the blue are the clients of our homeless shelters when they got COVID. And so you can see there were peaks in February, August, and December. And in the black are the shelter staff. And even though we were trying to prevent outbreaks, we were also trying to provide a safer workplace for our staff. And you can see that in all cases until December, there were far fewer staff getting sick than with COVID than there were clients. And you can also see that in most months, the numbers were relatively small. We only had those 3 months. Of course, December 2021 was the start of Omicron. And what I don't show you, because we haven't fully analyzed all the data for 2022, is this huge, huge Omicron wave that swept the entire country. And we saw a lot of Omicron, starting there in December. We did have a number of outbreaks. Outbreaks are defined as two or more people, which is pretty conservative. At one point, public health even had us for hospital-acquired infection. Even a single case was an outbreak, which was useful from an infection control point of view, but kind of useless from the point of view of saying, how many outbreaks do you have and so on. But anyway, in 23 facilities, we had 52 outbreaks. So about half our facilities did not have any outbreaks. The median size of an outbreak was 4 people, so they were pretty small outbreaks. And the median duration was 8 days. So again, pretty reasonably short. And that was, obviously we're not swabbing to prevent the first case of COVID. We don't know how to do that. We're trying to prevent outbreaks from that first case of COVID by isolating people and trying to minimize the amount of spread within these shelters. The majority did occur in congregate living settings. 17% of the outbreaks had 10 or more individuals. And Julia and I, when we were trying to come up with an analysis plan, decided that 10 would be a reasonable cutoff between a smallish outbreak and a larger outbreak. And then we saw that more of the outbreaks were in the emergency shelters or in supportive housing. And this is a little scatter graph where for the three types of shelters, emergency shelters top left, supportive housing outbreaks top right, and then drop-in sites on the bottom. What we've mapped here, and this Julia put this together, was the number of people involved in an outbreak versus the duration. And as you can see, there's, a relationship between the more people, the longer it goes on, the longer it goes on, the more people get infected. But you can see that visually below about 10, you see a clustering. We called those. And again, this was arbitrary in research. You go by what other people have defined, but then you try to come up with your own definition. So we had defined large outbreaks as more than 10. And what you can see is that the majority of outbreaks were fewer than 10 people. On the emergency shelter, you can see another clustering just over 10. And then you can see 3 outliers that were greater than 20. And one of these again, the top left, you can see an outbreak that had almost 60 people, and that went on for about 45 days. So that was one where, in fact, we knew there was COVID, but it was very low level. And in negotiating with public health, they did not declare an emergency because they stated, this is just a false positive. We had been seeing negatives, and so even a very low level positive to us was true infection. And so part of the reason for some of these outbreaks was kind of, a lack of clarity about the best ways of reacting to low-level COVID positivity at the beginning. But you can see the vast majority of these outbreaks were fairly small and fairly short-lived. And while we don't have a true comparator for this, we consider that a very good thing. So which outcomes are relevant? This is Marvin, who was featured in The Spectator back in 2021, was a big part of our studies, was lucky to go on eventually to his own housing, and unfortunately has passed away since that time. But what was important to people like Marvin? First of all, he wanted staff there. You couldn't have a shelter without staff. And the staff were very antsy at the beginning of COVID about working in a place where outbreaks could happen. So we want staff to feel safe. We want residents to feel safe. We want to prevent large outbreaks that are very disruptive for people and could be major health threats. And we also, because our research staff went into these shelters 1 time, 2 times, even 3 times a week, the staff became major providers of trustworthy information, initially around testing, around COVID, then later around vaccines, but also around other infectious diseases. So that was our first area, and we've been involved again in that for 5 people for 5 years now. I mentioned many of the people involved in this at the very end, but we'll go on to another area that we're really just starting right now, and that's Streptococcus pneumonia colonization and then serotyping in our shelters. So pneumococcal colonization is something that we know a lot of kids are colonized. Colonized means you have strep pneumo in your throat. We can grow it from your throat, from your nasopharynx, but it's not causing you any symptoms right now. But it does predispose to invasive strep pneumo infections, such as, strep pneumo can cause anything from sepsis, pneumonia, ear infection, sinusitis, etc. So in the homeless shelters in North America, it's known that there's a high incidence of respiratory infections, both viral and bacterial. And bacterial pneumonia in this setting is often Streptococcus pneumonia. And so in settings where people aggregating can pass this, homelessness has now been defined as one of the risk factors for needing vaccination. And so we have new conjugate vaccines. I mean, they're not that new. We've had the conjugate vaccine with 7 types called Prevnar 7 for about 15, 20 years. But in the last couple of years, we've had a great expansion of the number of strains that are included in the conjugate vaccines. So I usually look to NACI. NACI is our National Advisory Committee on Immunization. It's a public health agency of Canada, together with volunteers across Canada, academics, infectious disease docs, public health docs, pharmacists, etc. And what they recommended last year, and they recommend every couple of years when they look at new vaccines or new data, is that pneumococcal vaccination should be given to all adults in Canada over age of 65, or any adult who has risk factors. And they include things like heart disease, diabetes, HIV, but they also now include homelessness as a risk factor. So a 20-year-old who's homeless should get strep pneumonia. Now, obviously, this is the advice in terms of adults. All children are recommended to get routine vaccination, and that is offered and is quite well accepted throughout Canada. And then they do again now recommend vaccination in congregate care, regardless of any other risk factors. The Advisory Committee on Immunization Practices, or ACIP, which is another one that I follow, that's really part of the Centers for Disease Control. They've actually come out quite aggressively this year, saying that rather than 65, the risk takes off after age 50. And I'm not yet 65, but I'm certainly over age 50 and even over age 60. In any case, the Americans say we should actually vaccinate everybody in society after age 50 with a pneumococcal vaccine, and then those adults under 50 if they have additional risk factors. The pneumococcal vaccine, we've had one for 50 years. It's called the pneumococcal polysaccharide vaccine. It's got 23 different serotypes, which is great, but the quality of the antibody is not great, and the quality of the evidence for preventing clinically significant disease is actually miserable. This vaccine may make antibodies in a healthy person 50, 60, 70% of the time, but in those who truly need it, in the elderly and those with heart disease, lung disease, diabetes, HIV, it's probably got an efficacy somewhere between 0 and 30%. It's a pretty miserably bad disease. It's a cheap disease, it's a cheap vaccine, but it really needs to be replaced. So the two replacements for pneumococcal polysaccharide vaccine are either PCN20, so pneumococcal conjugate vaccine with 20 serotypes called Prevnar 20, or a new one from Merck called Capvaxive, which has been Health Canada approved. It's not, to my knowledge, on any provincial plans. And there's a debate as to the pros and cons of these two vaccines. And while our major emphasis in our study is to simply learn about carriage in our homeless shelters and trying to figure out, should we be vaccinating and how can we improve vaccination in our homeless shelters? Certainly, Merck was interested in sponsoring us in part because they want a lot more data on the serotypes. And one of the reasons we went to Merck is that we've developed a method for serotyping without having to culture, so that when you're getting, self-collected swabs, it's very easy to do PCR on them. It's very difficult to culture and to isolate, and especially since we've been putting these into molecular media that basically kill bacteria, so you can't culture it after that. So here's a nice table of vaccine serotypes. At the top, you can see Prevnar 7, which has been available for 15, 20 years. So most of our kids who had got vaccinated 5, 10, 20 years ago would have got this one. And then it went through different iterations of 10, 13, 15 variant. The newest one is Prevnar 20. So children today, if they need pneumococcal vaccination, and all children should get this, are getting Prevnar 20. In my HIV clinic, we've now started giving all of our patients Prevnar 20. So that's now the publicly funded conjugate sort of go-to conjugate vaccine for most things. And it's only a single shot where we used to, at least for adults, we used to give, let's say, Prevnar 13 and follow it up with a pneumococcal, with the polysaccharide vaccine eight or more weeks later. What I've highlighted here is even though PCV20 and PCV21 sound like they're only off by one serotype, there actually are many differences between them. And so what I've done is highlighted in yellow the differences between these two vaccines. So for example, Prevnar 20 doesn't have 9N or 15A or 16F, etc. So all the ones in the yellow. Whereas Merck, in developing their 21 valent, dropped some of the common things that we give to all children. And that seems a bit counterintuitive. But the data is if you have children who are widely vaccinated, you actually eliminate those strains from colonizing children, and therefore you eliminate them as a major source for adults getting infected. So adults then get infected with what we don't immunize our children against. So Merck has taken a kind of a big bet here by taking things that are almost complementary to what we vaccinate our children for and really develop this adult only. And I think time will tell whether this is a good strategy or not, but it certainly says we need a lot of really good data in the next few years on pneumococcal serotypes, both pneumococcal carriage and pneumococcal serotypes in different risk groups. So Julio Diaz, an undergraduate student who's working with us, is doing a study of looking at pneumococcal colonization. Done a small study comparing nasopharyngeal swabs with self-collected. The majority of clients and staff, we've got self-collected nasal swabs because that's what we used for COVID, and that's what we continue to do in a small way for some of our respiratory infections there. And then we do PCR on these. We do lit-A PCR. It's a test we also do in our clinical lab when we need to do PCR for strep pneumonia, for let's say meningitis and so on. And then so far we've just done a small retrospective study. We will expand this to about 800 people, both retrospectively and prospectively. But retrospectively on the first 50, surprised to find a full one-third of these were strep pneumo colonized. The mean bacterial density was quite high at 6.4 logs, and it was higher in this relatively small number of men we had. I think we had 16 men. 70% of them were colonized compared to 18% of women. So we just got ethics to go into the shelters and start a prospective study. So Julio and Kelly and Jody will be going into the shelters starting hopefully this month. We'll be doing a survey of vaccine attitudes, beliefs, thoughts around, influenza, etc. But also we'll be doing a self-collection of oral nasal swabs in order to look for strep pneumo. And then we do a CPS-AB PCR on these after the lit-A PCR, and that can then be sequenced with nanopore sequencing, and that's a method that Matt Surratt developed as a postdoc with me. So this is from some of Matt's slides. So Matt analyzed the whole capsular region of how strep pneumo makes capsules, and it's a very, very complicated process. But what he discovered is that the CPS-AB region is common to all of these, and that typing a region that's about 1,700 base pairs long relatively uniquely separates out most of the serotypes. The ones it doesn't separate, it might put into groups of 2 or 3. And so this is now a culture-independent pneumococcal serotyping method. He validated it against over 250 strains of strep pneumo that we got from Toronto and other places. He does the CPS-AB PCR. We sequence it with nanopore sequencing. And then this can call it, I think, 62 serotypes uniquely. About 20 serotypes will be called as one of a group of 2, and then some are called as a group of 3 or more. So we still need to design additional PCRs for those that are 2 or more. And in the initial comparison, he found about 97.6% concordance, although there were a number where there were, assembly failures or indeterminates, etc. But very, very promising initial results on this method. And so if you superimpose this on trying to separate, what you've got at the top now is the CPSAB can uniquely identify a number of these serotypes, or the remainder it'll put into clusters of, let's say, 3, or maybe even clusters of 8. And so we're going to use this to try to determine what are the serotypes. And so my last topic that I'm going to cover in just the last few minutes is a new topic that Jody Gilchrist in my lab, and she's our lab manager. She's been very active in all of our shelter health studies, but she's also been active in looking at better ways of screening and testing for sexually transmitted infections for about 15 years or more. And so she, as part of her PhD, has developed a study on sexually transmitted infections. She's teaching this morning because I invited her to co-present with me. And so just very briefly in the next few slides, she's interested in the common sexually transmitted infections, both bacterial and viral. We know that homeless shelters and homelessness is associated with higher rates, but also with less access to testing and treatment, they may have more chronic disease. And so one of the priorities in society in terms of trying to decrease the transmission of many of these has been to get to help people get tested who aren't currently getting tested, particularly if they're at high risk of being positive. So these are infections like gonorrhea and chlamydia. Today we won't talk about syphilis and HIV, but we'd like to study that in the future. And basically, so far in 9 different homeless shelters, we've Jody and her group have done a survey followed by self-collected urine and vaginal swabs for women, or urine only for men. And she's had almost 300 people, 60% men, 40% women, 2/3 of whom had not been tested for any STIs in the previous 1 year. And so these are then tested with Hologic Panther for GCCT and HPV, as well as the BD Max for GCCT and Trichomonas vaginalis. If they're positive for any of the reportable diseases, GCCT, they go on to public health for testing, and they get treated by the shelter health doctor. And we've seen rates overall of about 1 to 4% of the first 4 here, but in women, we've seen rates of up to 18%, and specifically human papillomavirus in women was quite common, and that's a group that's going to be, we're going to need better screening methods because they rarely get pap smears. So I'd like to thank you for that and give time for our second talk, but a very long list of people who have done a lot of this work. And then, of course, we've got our artificially created beaver running in the New York Marathon, just to sort of keep up both the Canadian thing and to keep up our interest in sort of this team sports that research very much is. I'd like to acknowledge our funders, HAXO, Ontario Health, Merck Canada, and the IIDR is sponsoring the current STI study. Thank you.
Thank you, Marek. I'd like to turn it over now to Jessica.
Thank you. So good morning, everyone. I think you can see my screen now.
Yeah, looks good.
Okay, excellent. All right, so today I'm going to share with you some main findings from a study funded by the COVID-19 Immunity Task Force of the Public Health Agency of Canada. And this study started during the pandemic. And even though it started during the pandemic, we're continuing to obtain new insights into COVID-19 infection and vaccination in older adults, and also new insights into how age influences the immune system. So first, let's consider how age affects the immune system. And if you ask most people in the general population why older adults get seriously ill from infections, they'll often say something to the effect of, well, their immune systems don't work as well. So there's this very common perception that there's this direct correlation between age and immune function, where the older you get, the less your immune system functions. And so it's generally thought that this is true, both in the absence of prior infection and vaccination, and even after vaccination, that older adults will have reduced protection from infections. So let's look at some real data. So this graph shows the number of COVID-19 cases in Ontario in early 2020 at the start of the pandemic by age group. And we can see by this dark blue line here indicating individuals over 80 years of age, followed by the dark purple line indicating individuals between 60 and 79, that older adults did account for most of the infections within this first wave of the pandemic. And as a result, maybe this is true. But if we look at the second and third waves of SARS-CoV-2 infections, we can see that in early 2021, young adults between 20 and 39 years of age, as indicated by this dark gray line, actually had almost as many infections as older adults. And in the second wave in 2021, or our third wave overall, there were significantly more infections in younger adults compared to older adults. So what changed? Well, primary two-dose vaccinations were administered to older adults, particularly those in long-term care and retirement homes in early 2021. And if we look at data specific for numbers of cases in long-term care homes in Ontario during that time, we can see that compared to the first wave, after these two-dose primary series vaccinations, so first dose approximate date indicated by that dark red line, and then the second dose by the dotted red line, afterwards there's this really precipitous decline in cases, which also corresponded with decreasing morbidity and mortality from COVID-19. But it's really important to note that this was not just due to vaccinations. Something that we should never forget is that in the first few months of the pandemic in Canada in 2020, older adults in long-term care homes in particular had the highest mortality rates from COVID-19 compared to long-term care residents in all other OECD countries. And major contributing factors to outbreaks and mortality were due to the design of congregate living, staffing practices, as well as inadequate infection control measures. And the latter in particular significantly improved by that third wave. But these epidemiological data of case numbers also suggested that it wasn't inevitable that older adults would always have poor immune function and thus poor responses to infection and vaccination. And so for the last few years, I've been extremely fortunate to work on a study that's been examining SARS-CoV-2 infection and vaccination in older adults in long-term care and retirement homes in Ontario within a study called the COVID and Long-Term Care Study. And so this study was an observational cohort of around 1,500 residents from 26 long-term care and retirement homes. And as you can see from this map, they were primarily located in the Greater Hamilton and Toronto regions of Southern Ontario. We also had sites in Sudbury and in Windsor. Long-term care and retirement homes in Ontario provide a variety of healthcare and other support services to their residents who in our study were on average 85 years of age. And if you're not familiar with the distinction between long-term care and retirement homes, individuals in long-term care are often more frail and thus have more comorbidities, and they require more assistance with daily activities such as hygiene and dressing, eating, and mobility. And so many long-term care residents also have Alzheimer's or other dementia-related conditions. So our study examined infection and vaccination with SARS-CoV-2 through integration of information from three sources. We looked at facility-associated information, including the type of the facility, number of outbreaks, staffing. But we also considered individual medical histories, looking at things like age, biological sex, frailty, pre-existing medical conditions, and vaccination and infection history. And combined with this, we also collected biological samples, including serum, whole blood, and PBMCs, to assess antibody and immune cells. And in particular, we were interested in looking at absolute levels of IgG and IgA antibodies against the spike protein, which the mRNA vaccines are designed to train the immune system to target, as well as the receptor binding domain of the spike protein. And we also were curious as to the quality of those antibodies. And so microneutralization assays were performed to assess the ability of those antibodies to neutralize the virus. And we also performed immunophenotyping to determine differences in immune cell numbers and to assess memory T cell responses to the SARS-CoV-2 spike protein after vaccination by using an AIM-based assay. And so if you look at a brief study timeline, we started collections in April of 2021, and then this continued about every 3 months after each vaccine until the end of our study collection period in July of 2023, so just over 2 years. And so our collections started after that primary series of vaccinations, and then sort of continued after third and fourth monovalent vaccines, as well as a fifth dose bivalent vaccine and sixth dose bivalent vaccines. And so one of the main questions that we really explored throughout our study was whether these vaccines were able to generate long-lasting antibody and cellular immune responses in our older adult participants. And so we looked at those antibody levels, their ability to neutralize the virus, and memory T cell population responses. And so what I'm going to do today is just provide you an overview of our findings by addressing some of the key questions that emerged during the study. Beginning with, well, do these vaccines actually generate nice antibody and T cell responses? And so I'm just going to show you a subset of data here, but we're looking at neutralizing antibodies. Here we can see after 2 vaccinations that in black, yes, there are responses, but they decrease over time significantly. And after 3 vaccines, we can see, yes, there is a decline over time. So there's a boost at the initial point of vaccination, and it does decline over time, but the waning is less than what we see after 2 vaccinations, and similar results after 4 monovalent vaccines. And so what these data told us really was that yes, the mRNA vaccines were able to generate antibody responses, but time since most recent vaccination, rather than dose number, was really important in maintaining humoral immunity, because you needed to have additional doses to maintain protection over time. And we can also look at T cell data to indicate whether or not we had good cellular immune responses. And so on the left here, we have memory T cell responses to the spike protein after 2 vaccines in the black, after 3 in pink, and then after 4 in the green. And we can see that the responses are present and they aren't necessarily waning as much as we saw with the antibody measures. And we see this for both, or we saw this for both CD4 and CD8 positive T cell responses. So memory T cells therefore remained in circulation for months post-vaccination, even up to 10 months, comparable levels to an earlier point after vaccination in some individuals. Another key question that we were interested in was whether vaccine type mattered. So we had Moderna versus Pfizer mRNA vaccines. And so these graphs illustrate something that we noticed throughout the entire study. So on the left, we have levels of anti-RBD, IgG antibodies. In the middle, we have neutralizing antibody measurements. And then on the right-hand side, we have our spike-specific memory T cell responses for CD4. And so within each of these graphs, we're comparing immune responses by vaccine combination. Individuals who received 4 Moderna vaccines, indicated in black, tended to have higher antibody levels, neutralizing responses, and memory T cell responses compared to individuals who received fewer Moderna vaccinations, as indicated in pink and green, and then all Pfizer vaccinations as indicated in purple. So vaccine combination, or rather more Moderna vaccines, seems to actually increase humoral and cellular immune responses. And this could in part be to the fact that the Moderna vaccine was a higher dose of mRNA than in the Pfizer vaccine, which worked a bit better in older adults, perhaps. Now, as mentioned, we also collected samples after bivalent vaccines became available. And so one of the key questions for us was, do these bivalent vaccines actually work better than the initial monovalent vaccines? So the monovalent vaccines were designed to target the ancestral version of the virus, whereas the bivalent vaccines targeted both the ancestral version and Omicron-specific variants. And so on the left here, we have neutralizing antibodies in green, shown after dose 4 for the monovalent vaccines. And then in purple, we have dose 5, the first bivalent vaccine, which was a mix of ancestral and Omicron BA1 spike mRNA. And we can see a slightly increased response over time, so less waning to Omicron specific neutralizing antibodies. And we also saw the same thing after dose 6, which was a mixed ancestral Omicron BA4-5 variant vaccine. And we look at T cell responses. Up here, looking at CD8 responses, we have monovalent in green, followed by dose 5 bivalent in purple, and then our dose 6 bivalent in blue. So there's definitely an effect of bivalent vaccination improving Omicron-specific antibody immunity, but maybe not T cell responses in particular. Because we had 2 different bivalent vaccines during our study, we're also curious as to whether there are differences in the types of responses that were generated after receiving that dose 5 mixed ancestral Omicron BA1 vaccine or the dose 6 ancestral Omicron BA4-5 vaccine. And as you can see on the left here for neutralizing antibodies, and the right for memory T cell responses against the spike protein, if we look at ancestral responses, there's a bit of a back boosting effect with the bivalent ancestral Omicron BA.4/5 vaccine, so dose 6, but the Omicron-specific neutralizing antibody responses weren't actually that different between dose 5 and dose 6. We didn't have an improvement in responses against Omicron BA.5 after that Omicron BA.5 specific vaccine. And we also saw no major changes or no major differences in memory T cell responses, whether against ancestral or Omicron-specific spike proteins. And so having this 6th dose that was specific for Omicron BA.4/5 didn't necessarily significantly improve Omicron-specific responses compared to that 5th dose, which is specific for Omicron BA.1. And so just to summarize what I've told you so far, what we found was that yes, older adults were able to produce antibodies and had memory T cell responses after vaccination. These antibody levels decreased within months, though cellular responses were maintained for a much longer period of time. Bivalent vaccinations seemed to improve Omicron-specific antibody responses, but the bivalent vaccines specific for Omicron BA.1 and Omicron BA.4/5 had pretty similar antibody and cellular responses over time. But we also found that vaccine type influenced immune response. And so data from this study were used by provincial and national health authorities, as well as NACI, to allow them to assess seroprevalence, as well as to guide evidence-based decisions regarding vaccination in terms of when and how to vaccinate older adults. And so to go back to our original question, about whether vaccination responses are lower in older adults compared to younger healthy adults, what I'm going to do is show you data from our study and compare it to data from a cohort of younger healthy healthcare workers from a study called the Timing Study. And so the data from young adults is courtesy of that study run by Dr. Mylan Duo of the PHRI. So on the left here, we have neutralizing antibody levels compared between our older adults in long-term care and retirement homes and younger adults within that timing study. And we can see after 2nd, 3rd, and 4th monovalent vaccinations, if we just look at the red lines, which are the median, that they're not terribly different between younger healthy adults and older adults in our study. And we can also look at the T cell data, where again, the medians are quite similar across all of our doses. What you can see perhaps is that there is a lot more heterogeneity in the older adult responses, and that there's more people who fall below the limits of detection perhaps than above the limits of detection. But overall, these data suggest that older adults don't consistently have lower antibody or T cell responses after vaccination compared to younger adults. So maybe this isn't actually true. And if you're thinking that maybe some older adults do actually just have lower responses to vaccination consistently, I want you to consider these 3 graphs here. So on the left is data for our antibody levels for anti-spike IgG. In the middle, we have neutralizing antibody responses. And then on the right-hand side, we have spike-specific T cell responses. And each of these colored dots indicates a unique individual. So for example, our red dot here, this individual has great antibody levels, but these antibodies are really poorly neutralizing, and they have around average T cell responses. Whereas this blue dot, for example, they have really poor antibody levels, but those antibodies are really good at neutralizing the virus, but they have poor T cell responses. And then we have someone like the purple dot who has great antibody levels, and they're above average for their ability to neutralize the virus, and they also have rather robust T cell responses. So there's significant heterogeneity across all the measures that we took in our study, and looking at immune measures alone wasn't able to give us an indication of a correlate of protection. And something that we also noticed over the course of our study was, especially in the Omicron era, illustrated by this graph here, where this indicates the number of outbreaks of COVID-19 in long-term care and retirement homes in Ontario from late 2021 through to the end of our study collection period. And you can see we went through these increasing and decreasing numbers of outbreaks in Ontario, which were also reflected in the homes within our study. And this increasing numbers of outbreaks roughly coincided with the emergence of new Omicron variants. So even though the number of infections and really morbidity and mortality was significantly decreased in the Omicron era compared to the initial wave of infections in the pre-vaccine era. Many older adults remained at risk and were being infected with Omicron SARS-CoV-2 variants, even though they had really high vaccination rates. And so another key question within our study was what factors were contributing to Omicron infection susceptibility despite these high vaccination rates. And so what I'm going to do is just give you a very broad overview of some of our findings from investigations across 4 distinct periods of Omicron infections. So we have what I call the early Omicron infections when Omicron first emerged from late 2021 to about May of 2022. Then we have when Omicron BA.5 first emerged in the summer of 2022. And then we have our late Omicron BA.5 phase in the fall. And then we have our Omicron BQ/XBB mixed infections as our 4th period of time. And so what we did through these 4 periods of time is we used Cox proportional hazard regression analysis to assess potential risk factors of Omicron infections. And across all observations, we found that both age within our cohort and biological sex were not associated with infection risk. Frailty for when data was available had no effect on the instance of initial Omicron BA.5 infections, but was associated with significantly higher risk of Omicron infections within this late BA.5 period and that BQ/XBB period. We also looked at whether recent vaccination and more Moderna vaccinations were able to reduce the incidence of infection. And we found, interestingly, that this only had an effect within certain periods of time. So a monovalent vaccination that was recent was able to reduce the risk of infection within this early Omicron period. And a bivalent vaccine was able to reduce risk of infection with this later period, but within the BA.5 period of Omicron infections, recent vaccination was not associated with lower risk of infection. Across the board, however, we saw that more Moderna mRNA vaccinations were associated with lower risk of Omicron infections. We also investigated whether recent infection would have a positive impact because generally what happens or what is thought to happen is that if you have an infection and vaccination independently, you're going to get increased protective immunity, but combined, you have this enhanced hybrid immune response, which should provide increased protection against future infections. And when we looked at this, we saw that for our early Omicron period and then the late BA.5 period, and also to the end of our study, that a recent infection and thus hybrid immunity or presumptive hybrid immunity was associated with a lower risk of Omicron infections. But we found within this early Omicron BA.5 period that actually recent infection was associated with an increased risk of infections. And so just to briefly highlight what we found when we've investigated this further, we found that antibody levels were probably to blame. So individuals who had a early Omicron BA.1, BA.2 infection, as indicated on these graphs by the dark or by the light blue dots, they had increased antibody levels and neutralizing antibodies after their infection. But if we took these people who had these early Omicron infections and they considered whether or not they had a reinfection within that Omicron BA.5 period, we found that the people with reinfections actually had much lower antibody levels and neutralizing antibodies. So decreased hybrid antibody immunity and the lack of actually enhanced protection from hybrid immunity seemed to be to blame for that increased risk or associated risk of Omicron BA.5 infections. And we also looked at whether this was due to underlying immune suppression or pre-existing immune defects, but we found, as illustrated by these neutralizing antibody levels, looking before any Omicron infections happened, that people who had infections during the Omicron BA.5 period after initial Omicron infections actually had pretty similar antibody levels as well as cellular immune responses before any Omicron infections compared to everyone else by their future infection outcome. We also found that after reinfection, that these individuals who were reinfected did have a nice, robust antibody response and also cellular immune responses. So this suggested that there was just something unique about these individuals who, after their initial Omicron infections, they didn't mount really strong antibody responses, which put them at increased risk for subsequent Omicron BA.5 infection. And we're still investigating further reasons as to why this occurred. So in summary, risk factors for Omicron infection really changed by variant and over time over the course of our study. And so more broadly, we can't always predict now or in the future what will be protective. And as a result, timely vaccination is really our best bet to maintain protective immunity against COVID-19 and to reduce severity of infections within vulnerable older adults. Because as we can see from this graph showing outbreaks in long-term care and retirement homes in Ontario from the beginning of the pandemic to this month, that the number of outbreaks that we're currently seeing is not dissimilar to what was seen earlier in the pandemic. So COVID-19 continues to significantly impact older adults in congregate care settings. And so I'd like to acknowledge our interdisciplinary and highly collaborative study team, which was overseen by Dr. Don Bowdish and Dr. Andrew Costa, as well as our long-term care and retirement home participants and staff. And thanks everyone for listening as well.
Great. Thank you so much, Jessica. Well, we wait for some questions to pop up in the chat. I have a couple of questions for you guys. I'll start with Jessica, since you're still on screen. I'm very curious to know why the immunity to COVID wanes so quickly. So, I've had 2 infections and probably 6 vaccinations. And from what I'm hearing, that's not really going to save me unless it's been recent.
I think so. With vaccine development, we're always behind, which is because of the virus keeps mutating over time. So we're always behind. In the Omicron era in particular, at the beginning, we had our ancestral monovalent vaccinations. And if you remember, I showed some data suggesting that a recent monovalent vaccination decreased the risk of infection, even though it wasn't a perfect match to the Omicron variant that was circulating, it still decreased risk. So the quantity of antibodies rather than the quality of those antibodies seemed to be important. And so I think that with the current or continued evolution of the virus, we're never necessarily going to have a perfect match with the mRNA vaccines that are targeted against the spike protein, because it's the spike protein that really is mutating a lot over time. And so
does that suggest that we're not looking at the right antigens and that we should be focused on something that's more conserved?
So my colleagues in the IIDR will tell you that that's why they're developing a mucosal vaccine that looks at, or rather incorporates not only the spike protein, but also the nucleocapsid and the RNA-dependent RNA polymerase. And so the RNA-dependent RNA polymerase and the nucleocapsid, they are a lot more conserved across variants. And so we only would expect to get exposure to those through natural infection right now. So if you perhaps include those in vaccines, you might be able to help reduce some of the variant-specific changes in infection risk. But even then, there's possibly in certain populations, just intrinsic factors that don't lead to, or rather that lead to a significant reduction in antibody levels within a rapid period of time, irrespective of whether you've been vaccinated or not after infection.
Okay.
So more research is needed.
Yeah, I'm looking forward to this vaccine, not just for its, triple antigen, but also the mode of delivery, I think is very cool. Okay, my question for Marek is, so I was quite struck by the differences between the Merck and Pfizer pneumococcal vaccines. So is there any recommendation or advantage to doing both vaccines, or is that counterproductive for some kind of reason.
I think time will tell. I mean, if we're doing Prevnar 20 in all kids, there's got to be a delay between when we start doing that and when colonization virtually disappears. But unlike our COVID vaccines, our conjugated strep pneumo vaccines are so good that you not only eliminate disease from that serotype, you eliminate colonization from that serotype. And so
Mhm.
what you then it's whack-a-mole. Whatever you vaccinate with, the kids will end up with other serotypes. They're
Mhm.
not as deadly, but they will still have strep pneumo at least 80% of the time when they're young kids. So I absolutely agree with you, though. I think one of the fascinating things will be Prevnar 20 is what I'm giving, let's say, my HIV patients, what we're giving adults at risk. Is the Merck 21 going to be a better vaccine, or are we going to end up with the two complementary ones? I think for sure we're no longer going to use pneumococcal, the polysaccharide 23 valent one, because we're quite convinced that that's not a great vaccine. But I'm looking forward to 5 to 10 years of intense rivalry between these companies. It should fund some really, really good research. But one possibility in high risk patients is exactly what you suggest. Maybe in the end they'll need two vaccines. So.
Yeah, that's so interesting. Okay, let me check my question box. I don't see any outstanding questions, so I guess we will. Oh, I take that back because Rubiet just raised his hand. So let me see if I can track down Rubiet. Where are you in my list? And let me allow you to talk. There
I
we
think I think I tried to do that.
go. Okay.
All right, thank you.
Ah,
Can you hear me?
Yep.
yes.
Okay, good. Thank you, Marek and Jessica. Excellent talks. I actually have a question to Jessica. Actually, it was very interesting to follow your presentation because I have been involved in population-based vaccine studies, like kind of investigating almost every questions you have, and they're so nicely correlating. So I have just one question. Like in one of the studies, we have seen that um, we termed it like double primed vaccination versus double prime natural infection versus Omicron primed. So with double prime means one person who had a pre-Omicron infection and then a Omicron infection and then a subsequent reinfection with Omicron, they had lower protection from the infection compared to the ones who had two Omicron infections. So I think we termed it as like immune imprinting. So I was just wondering if you comment on that from your end of the studies.
Yes. So data I showed in vaccinations today was specifically in people who didn't have infections until the very end, when I showed those antibody results after initial Omicron infections. But prior infection definitely has an impact on subsequent antibody and cellular immune responses. The effect does wane over time. And so individuals who had an infection like at the beginning of the pandemic, before they had any vaccinations, that definitely had an impact on increasing their antibody levels and T cell responses in a few months after they received their initial vaccination, and maybe even a year or so afterwards. But sort of 3 years into the pandemic, there's no lasting higher antibody levels or T cell circulating T cells as a result of that initial infection. But imprinting is definitely a concern. Something we noticed with the sixth dose, the ancestral Omicron BA.4/5 vaccine in particular, was that individuals who had prior infections, though I just showed the absence of infection data today, they seem to have back boosting in particular against the ancestral variant, or maybe the Omicron BA.1 variant, if that's when they had their infection. So there is definitely an effect of prior infection history that influences both humoral and cellular immunity.
I want to point out that, if you look at influenza, we're all geared up every October. We vaccinate against influenza. We get that short-term immunity from influenza that hopefully decreases hospitalizations and deaths. One part of us think that's what we want to get to with COVID, where it's primarily going to be a winter disease. But I would, right now this is endemic. We have COVID all the time in Canada. Even if we shut our borders, it wouldn't go away. In some ways, that's good because we actually know what the strains are going around, the endemic strains, so we can probably better understand the vaccines and how they work for that particular strain. And the mutations hopefully will be smaller. If in the next few years we get to a more seasonal pattern where we have no COVID for 6 months a year, we're then going to have it reintroduced from somewhere else in the world where we won't know and won't be able to predict which one comes in, which vaccine to use. And we're going to be back to what we do for flu, which is guess which strains are coming. And if we make a bad guess, we have a really, really, really bad flu year. But I do think that immunology of this and the worldwide spread and the seasonality are going to be fascinating things. And of course, influenza A, we've dealt with this since 1918. And even though it killed a lot of people initially, it's killed a lot more people in the 100 years since cumulatively. COVID is still killing people. And I don't know what to wish for. Do we want it to become seasonal so we only get vaccinated in the fall? Or do we want to keep it endemic so that we actually know what to kind of prevent down the road? So it's going to be fascinating for everyone, immunologists, epidemiologists, clinical trialists, and of course, people managing hospitals.
It sure is. There's no end of research to be done. And I want to commend you both for, taking your research out into the messy real world, because I know it's a complex situation to work in. So thank you both again for great talks and good discussion. And I will see everybody next month.